This video demonstrates the technique of transanal endorectal pull-through for Hirschsprung's disease in a 6-month-old child who had a rectosignoid transition zone. The child was placed in lithotomy position. The first step of the operation consists of everting the anal canal by taking mucosal stitches 1 cm above the dentate line, which are then anchored to the perianal skin about 1.5 cm distant from the anocutaneous margin. And here you can see 3 of the sutures already in place and the 4th one, the anterior, being tied.
More of an end-on view.
No, the side view. Stop record now.
Depending on preference, a total of 8 everting stitches is inserted. The next innermost ring of sutures are 4 marker stitches which demarcate the mucosal margin where the incision will be made. These are inserted at 12, 3, 6 and 9 o'clock position and remain till the end of the operation. The position of these marker stitches is about 4 mm inside the previous everting sutures. One is to 400,000 lignocaine with adrenaline is infiltrated into the submucosal plane of the everted anal canal to dampen intraoperative oozing when the mucosal tube is separated from the underlying submucosa. The third layer of sutures consists of 16 mucosal stitches, which are again 3 mm inside the marker sutures. These stitches help to exert uniform traction on the mucosal tube of the rectum as it is dissected upwards into the pelvis. As these sutures are inserted in each of the 4 quadrants, they are held with individual hemostats so that uniform traction is exerted on the mucosal tube. And here you can see the traction sutures in each of the quadrants, due to which the anal canal is everted and displayed, ready for making the mucosal incision. It is my preference to begin the incision at the 3 o'clock position, but this is very much the individual surgeon's choice. Exerting medial traction or inferior, as the case may be, anteriorly on the traction stitches, the mucosa only is divided circumferentially, equidistant from the marker sutures.
बंद हो गई तो बंद हो गई.
The incision is completed all around the circumference of the anal canal, taking care to divide only the mucosa. Submucosal dissection is then begun again at the 3 o'clock position. Exerting traction on the mucosal stitches displays strands of tissue anchoring the mucosa to the submucosal layer of the rectum, and these are divided using fine scissors, freeing up the mucosal tube from the underlying submucosa. There is a natural plane between the mucosa and submucosa, and it is helpful to enter this early on and then to proceed with circumferential dissection, keeping inside this plane, as this will prevent damage both to the mucosal tube and the underlying submucosa. So just continuing to divide the strands which are anchoring the submucosa and the mucosa together, and one can see that we are staying inside the anatomical plane using the traction sutures in a successive manner to separate the mucosal tube from the underlying submucosa.
But we need a little mop.
Now, it is important to note here that the internal sphincter of the rectum is very closely adherent to the mucosa in the distal most 1 to 1.5 centimeters above the anal canal. Therefore, the mucosal tube that we are seeing being separated here consists not only of the mucosa but also of the circular fibers of the internal sphincter. It is important to realize this fact, as subsequently in the dissection we will very deliberately enter even further inside these circular fibers to reach the mucosal tube proper. Without doing that, the dissection continues outside the smooth muscle of the rectum and will eventually turn full thickness. Now here you can see a fine forceps is being used to coagulate deliberately through the fibers of the internal sphincter so as to continue further dissection strictly in the mucosal plane. The layer of muscle is thick.
आ रहा है, बढ़िया आ रहा है, थोड़ा सा head and a little mop.
So the fibers of the internal sphincter are coagulated circumferentially round the circumference of the bowel. It is important to stay in the same circle, otherwise one will tend to spiral upwards into the anus, making things difficult. However, if we stay at the same level, at one point we will see that the muscle parts to reveal the underlying mucosal plane, and further dissection will then continue in this plane to release the rectum. It is important to pick the fibers up and pull them away from the underlying mucosa, otherwise it is very easy to perforate the mucosa and that can lead to problems. So anteriorly we can clearly see the last few strands of muscle fibers being divided by the diathermy and the underlying pale grey mucosa of the rectum coming into view. It is now also possible to appreciate the full thickness of the internal sphincter in this area, as the muscle is fully 2 to 3 millimeters thick. Once the mucosa is delineated at a particular point, it is easy to follow that plane round the circumference of the bowel and free the internal sphincter completely. It is important to do this step carefully, as this will make subsequent dissection fairly simple.
You want me to say it? बिल्कुल ठीक है सर, मैं कह दूँगा सर। ये ओटी में हूँ। हाँ हाँ बोलिए। ठीक है सर। हाँ बिल्कुल ठीक है।
नहीं लिखे तो स्टार्ट करेंगे तो अभी तो अदरवाइज इंट्रॉफी कैसे होगी? Sometimes, if the child has had previous enterocolitis, this dissection may be a little more difficult than usual as the mucosa is densely adherent to the internal sphincter. However, with perseverance, it is nearly always possible to pick out the individual fibers and release the mucosal tube. Now we can clearly see the junction between the internal sphincter and the mucosa here. That's a small perforation which has been created in the mucosa. However, since the fibers have nearly all been separated, this should not give us any undue problem.
Not to sort of tell you, but I tell you what my experience is. In a branch that is less known, there is all of which were given nobody records everybody said कि समझ में नहीं आ रहा from
Once all the muscle fibers have been divided circumferentially, it is then possible to actually sweep the more proximal muscle upwards into the pelvis and free up increasing lengths of the mucosal tube of the rectum. Inferiorly, one can clearly appreciate the thickness of the muscle fibers in this area, and each of these have to be divided. You can clearly see the edge of the muscle there with the underlying mucosal tube. Every millimeter of this has to be divided to facilitate subsequent dissection. So there's the more proximal muscle being stripped away with a combination of coagulation and upward traction, and increasing lengths of the mucosal tube will now come into the wound. It's also important to note that the dissection proceeds mostly within 1.5 centimeters of the anal verge. One should avoid the tendency to go progressively into the anus where visibility is poor and difficulties may arise. As far as possible, using gentle traction on the sutures, the area of dissection should be kept within 1.5 centimeters of the anal verge.
But it is very non-monetary. The setup is getting better, but the mental status is still the same. So, and Swami is really taking it.
One should use a combination of sweeping the muscle upwards together with coagulation. There are a large number of vessels anchoring the submucosa and the muscle of the rectum to the mucosa, and if they get torn, they lead to troublesome oozing, as can be seen here. Therefore, it is important to use coagulation fairly judiciously to prevent the operative field by getting obscured by blood. So there's the muscular cuff of the rectum getting progressively swept upwards using a combination of gauze dissection and diathermy coagulation. And as I mentioned before, we do not enter more than 1.5 centimeters into the anus to keep the dissection completely under vision at all times.
फिर कर लेंगे भाई, ऐसा कुछ वो थोड़ी ना. There is no
बात नहीं है.
हाँ. Poor case for this kind of a surgery. अच्छा.
He's got enterocolitis. ये जो खुरदुरा सा है.
नहीं. Do you want me to take the intestine that you have pulled out? Because अभी तो हम anal words पे ही focused हैं.
एनल वर्स पे रहो.
भाई साहब इसके पास का कोई मैसेज है? वो पूछ लेना, भूल जाऊँगा ना तो बता.
ठीक, नो प्रॉब्लम. मसल यार पूरी नहीं छूट रही है. As the rectal cuff gets swept upwards, we can see that the mucosal tube is dilating slightly, and this means that we are now approaching the transition zone. Of course, as I mentioned before, the strands contain vessels which run between the mucosa and submucosa, and they have to be carefully coagulated off. Nearly 5 inches of the bowel is now outside the anal canal, and we are approaching the level of the peritoneal reflection of the rectum. This is signaled by sudden thinning of the muscular cuff anteriorly, and once this level is reached, it should be achieved all around the circumference of the bowel by separating the muscle from the mucosa.
चाबी कैलाश के पास है, लेकर निकालो कमरे से.
Okay, zoom out and show that.
Zoom out and show. अब तुम बिल्कुल ही तुमने हनुमान जी की पूंछ बना दी है तो कैसे? हाँ ये ठीक है, रुक जाओ 1 मिनट.
So here we can see that a good 7 inches of the mucosal tube has now been extracted through the anus, and there is a slight widening at the cranial end where the transition zone begins. And as is the general rule, we will excise the bowel till about 5 centimeters above the transition zone. We can now clearly see where the peritoneal reflection of the rectum is present anteriorly, and this will now be grasped in a couple of hemostats and divided, and there you can see the serosal surface of the rectum with the muscular cuff inside the anal canal.
This is mucosa.
So that is the distal sigmoid being pulled into the incision till about 5 centimeters above the transition zone, which will form our level of bowel section. And it is clearly visible where the intestine funnels from the transition zone into the aganglionic segment.
Light दे दो बस. ये देखो. Are you satisfied?
If the transition zone is as clearly visualized as here, we can get away without a frozen section facility, but ideally it is important to take frozen sections from the colon to ensure that the bowel has been resected to completely include the aganglionic zone in the excised specimen. So here we are coagulating through the last few remaining strands of the mesentery of the distal sigmoid to free up the mucosal tube completely. If you want to excise a greater length of the bowel, then the vessels in the posterior mesentery may also be individually
Okay, can you see
isolated and ligated. However,
Can you see this area?
using coagulating diathermy, it is quite easy to coagulate these vessels at two places and allow them to retract inside the anus.
ब्लड वेसल की जो काटी
हाँ ऐसा बोला और नहीं आ रहा Okay, now can you just need to show that this is the transition zone. ठीक है? Got that?
बिल्कुल बिल्कुल
Don't try anything.
ठीक, I think that is enough resection. यहीं पे रिसेक्ट कर देंगे. ओके, अभी रिकॉर्ड करना हमको.
चल रहा है वी हैव एनफ ऑफ
सीजर सीजर. अरे सॉरी. अब ये एक्सटेंड दिखा दो.
एक्सटेंड
ये उल्टे पॉटी तो निकले ही नहीं.
जस्ट
Zoom out and show the extent.
ओके फेयर एनफ
Yeah.
फेयर एनफ
Having decided the line of resection, we now proceed to transect the intestine 5 centimeters above the visualized transition zone. The bowel is divided using diathermy and the specimen removed. Good bleeding is seen from the proximal edges of the intestine, which tells you that the coagulation of the mesentery has not been too drastic.
Stay seated. Quite well. Intestinal clamp.
ना करती
It is vitally important to prevent rotation of the proximal intestine when the coloanal anastomosis is performed. For this purpose, it is best to fix the point at 6 o'clock with the first suture, which will prevent any further rotation of the intestine as the anastomosis progresses.
Okay, hold that away. No, right from the edge. Now,
As can be seen here, the edges of the proximal colon are sutured to the mucosal edges of the rectal mucosal cuff, which was demarcated by the 4 marker sutures.
We'll catch only the four quadrant ones.
Again, we are at a point where personal preference and comfort dictates the technique followed. Some surgeons prefer to hold each of these stitches in an artery forceps until the anastomosis is completed. However, once the bowel is fixed at 6 o'clock position and rotation prevented, it is a little easier to keep the operative field as free from non-essential stay sutures as possible.
Cut this suture also.
अंदर ऊजर तो नहीं है,
हैं?
एक ऊजर तो नहीं है,
नहीं, ऊजर तो
Five
skin edge
o'clock
में,
पे?
skin edge में.
अच्छा
That is a bowel edge, sorry, not skin edge,
अच्छा।
bowel edge. वो भी दिखाएंगे.
The edge of the anal mucosal cuff is clearly visualized and accurately opposed to the edges of the proximal colon. Care is required for this anastomosis because the patient will be passing stool through it, and prevention of leakage is vitally important. Even then, it is prudent to avoid too many sutures during this anastomosis. I have found that 4 sutures in each quadrant, leading to a total of 16 around the circumference, is usually sufficient.
एक मिनट ओके वो
Again, the anal mucosal cuff clearly visualized and being accurately approximated to the cut edge of the proximal colon.
दबाएं. छोड़िए. अरे वो यार जहाँ आपको कष्ट हुआ छीलने में वहाँ सही कटौती ये तरीका
वंडरफुल बिल्कुल बढ़िया
इधर क्या करना है तो नहीं तो वो काटो ना, वो एंकरिंग हेडेक है तो उसको काटो इससे आप लिमिटिंग है, दोनों तरफ से करते हुए चलते हैं।
So here we have the last few stitches of the coloanal anastomosis, and you can see that the circumference of the bowel is pretty well secured. A degree of mucosal edema develops as a result of all this manipulation, but this quickly subsides when the intestine is reposited inside the pelvis.
Light.
It's important to mention that this video was recorded entirely by my younger brother, Dr. Anupam Baklu, who is now a consultant in the same institution where I work, in the Department of Rheumatology. So thanks are due to him for giving you a clear picture.
सर थोड़ा सा लैटरल रिट्रैक्टर ये बस
अरे वो ना भी दिखे
नहीं, ठीक है।
आके बैठता ही
The suture bites out of the thin rectal cuff, in which case another bite can simply be taken near the anal verge to secure the colon edge.
Kailash nasal twang is reduced over the years.
Actually, everyone has picked up the
Nasal twang when I last heard him.
चढ़ भी तो उससे चिपका हुआ है। ठीक हो गया, शायद उसके बगल में।
Ventral
So that is the last stitch of the colonal anastomosis,
close नहीं लिए suture.
हाँ, बिकॉज एंटीरियर जनरल पेरिटोनियल कैविटी होती है ना।
Okay. That is the place जहाँ से खेल होता है.
हाँ, ये
which is from the position of our first incision
उससे क्या फर्क पड़ेगा?
about a centimeter and a half from the anal verge, 5 millimeters above the dentate line,
तो उससे क्या फर्क पड़ेगा?
thus preserving the anal canal and its surrounding
Okay.
striated musculature and not affecting continence. Once the returning sutures are cut, the colon can be reposited inside the anus. Dividing the last little tag of mucosa, which was held in one of the anchoring sutures.
नीचे रुक जाए.
डायलेटर और वो बीटाडीन आंसर लगा दे बीजे डायलेटर।
Very good. अब इसको तुम DVD पे ट्रांसफर करवाना.
As the anus has been dilated preoperatively and the child is still under relaxation anesthesia, we do not see the anus contracting immediately. However, anal tone returns very quickly in the postoperative period, and we have not had incontinence in any of our patients following this procedure.
जूम इन करके जूम आउट कर लो बस, ऐसे खड़े करो। ओके,
बढ़िया. इसको साफ सूफ करो. रख के रहिएगा.
सर मैं थोड़ा क्लोज जा रहा हूँ.
This is another view of the resected specimen, and we can see that nearly 13 centimeters of bowel has been removed, and this is after the intestine contracts. The histology showed normal ganglion cells at the proximal end of the specimen, and the child did well postoperatively. This is a view of the preoperative contrast enema. There is a mild degree of overfilling, but it is possible to appreciate the funneling of the bowel at the rectosigmoid junction. The children are allowed orally after recovery from anesthesia, and we give cefotaxime and metronidazole for 3 to 4 days. The child was followed up till a period of 1 year and remained well. Thank you.